I'll pass it over to Erin. Erin Tucker is our President of Employee Benefits here at the Miller Group. Erin.
Thank you, Amanda. Good afternoon, everybody. It's my pleasure to welcome you all to this important session on navigating the future of medical benefits. We have a diverse audience here joining us on this webinar today, including leaders from various industries, companies of different sizes, both self-funded and fully insured. The concepts we'll talk through today will lean a bit more firmly toward those self-funded plans. However, the cost drivers, many of those cost drivers addressed today, will be applicable to all types of plan funding. Our ultimate goal today is to provide you with some valuable insights into the various elements that impact medical coverage costs. And we do acknowledge costs continue to be on the rise, and it's important to be well informed about the current landscape, which includes that focus on cost containment, price transparency, prescription drug costs, and the ever-changing role of the federal government. We have an excellent lineup of speakers today who will share their expertise on these topics. To start, we're going to hear from Tracy Johnson, Director of Pharmacy Benefits at the Miller Group, who will discuss the pipeline of costly drugs, gene therapies, and cost containment ideas. Next, Brett Lane with Voya will provide insights to stop loss and reinsurance, including the impact of high-cost claims on rates. And finally, Jayson Cuba, Benefits Advisor with the Miller Group, will share strategies for handling high-cost claimants and innovative cost containment examples. As Amanda mentioned, we will conclude the session with some Q&A, so please be sure to put those questions in the chat as they pop up. And thank you again for joining us. With that, I'm going to hand it over to Tracy, our Director of Pharmacy Benefits.
So as Erin mentioned, today we're going to talk about the 2025 healthcare forecast and how it relates to medical and pharmacy. So there are several reasons why we're looking at growth between 24 and 25. Healthcare spend, according to PricewaterhouseCoopers, is expected to grow about 8%. There are various drivers they're responsible for this growth projection. We have inflation, behavioral health utilization, CMS price transparency, the No Surprises Act, and the Inflation Reduction Act. All that being said, I'm going to focus, like I said, on the pharmacy benefit aspect of the anticipated growth and those trend drivers. So here's a list of what we're going to talk about throughout the following slides. Of course, we've got GLP-1s, it's everybody's favorite topic. We're going to talk about how they relate to diabetes and weight management. We're going to talk about central nervous system agents and what those are, biosimilars, cell and gene therapy, and orphan diseases. So starting with GLP-1s, and I want to acknowledge the fact that this is such a big topic that we could spend all of our time visiting about just this one topic alone. So I want to spend a couple of slides discussing it because I think it's really important. GLP-1s for type 2 diabetes have been around since the early 2000s. There wasn't much of an uptick at that time. The medications that were out were injectable. They had to be injected twice a day. And the outcomes really, we've come a long way as far as that goes. In the last few years, we've had a couple of new GLP-1s hit the market, and I know they're kind of commonplace household words now. We've got Ozempic, we've got Mounjaro, and those are both FDA approved to treat type 2 diabetes only. One of the side effects, there's many side effects to those medications, but one of the side effects that people found, weight loss. So out of that, we found these medications were being prescribed off-label, and you may remember, this over the last couple of years, they're being prescribed off-label, and as a result, there was a drug shortage a pretty large drug shortage when it came to these two medications. So because of that, PBMs and health insurance carriers had to get really thoughtful about coverage for those medications specific to type 2 diabetes. So we saw an increase in prior authorization criteria. We because of that, there was a lot of noise from employees, from employers. You know, why was I getting this medicine all along, and now I'm having to wait or jump through special hoops? Well, it was because they were trying to protect the drug supply, make sure that medication was being taken for the right person for the right diagnosis. So I feel like we have gotten kind of past that. I think everybody's comfortable with how that has been working and what we're used to as far as the diabetes component. But again, the side effect being weight loss, the manufacturers of Ozempic and Mounjaro came out with FDA approved versions for weight loss specifically. So now we have two types of GLP-1s that are very expensive that we get the ability to cover on our plans if we're fully insured. GLP-1s for diabetes are covered. If we're self-insured, there's the opportunity to cover weight management GLP-1s. On the fully insured side, I was talking this morning, all but one carrier that I'm aware of provides coverage for GLP-1 weight loss version, and that's with a buy-up. So other than that, I don't think to date there's any fully funded medical plans out there that offer it. So some of the things I'm going to talk about here will apply maybe more towards self-funded groups, but I want to make you aware that this is out there. It's definitely a trend driver, and I think everybody can agree that it's an important topic. So, like I said, one of the side effects being weight loss, it's all over the news, right? The social media, in the news itself, I don't think you can watch any program without seeing several commercials throughout the length of that program for medications like this. You see people running through the park, dancing. They're very excited. They're on one of the medications for diabetes, and it says, oh, and may result in weight loss. So everybody wants to find out more about it. Folks are asking their doctors about these medications. The direct-to-consumer advertising that's happened is really unprecedented, and we're seeing TV ads, commercials for specific to the weight management piece. If you're in the Kansas City area, Weight Watchers, Slim for Life, they have programs that you can enroll in and get access to the weight management GLP-1 options. The direct-to-consumer advertising is mostly for the compounded versions of these medications, but it's so prevalent that it's on everyone's mind. I want to mention the GLP-1s. Okay, we know about the type 2 diabetes, weight management, and then they've recently been FDA approved to treat sleep apnea and diabetic neuropathy. So these are really important medications, and I think that it's important that we understand, in addition to the direct-to-consumer marketing, the social media, why we're hearing more about this now. I don't know about you, but we have clients, we have employees asking for coverage. They want to know if they can get this medication covered by the plan. And there are considerations to think about. PricewaterhouseCoopers did a study recently, and 30 to 40% of self-insured employers are now covering these medications for weight loss purposes. That being said, none of the Miller Group clients are doing it yet, but the reason to consider it is very important. Obesity is a major factor in the United States around 40% of United States citizens meet the definition of obesity. So these stats are coming from the CDC. The definition of obesity is a BMI of 30% or greater. Severe obesity is the definition of 40% or greater BMI. So, I think that touches a lot of people. It is something that if we can address, that the outcomes for other health conditions would go away. So we've got high blood pressure, heart disease, kidney issues. There's all kinds of things that go along with the diagnosis of obesity. So covering a medication that would help prevent or reverse that is really important. So thinking about coverage for weight loss. So these medications, I want to point out, they're not curative in and of themselves. They're proven to work. The commercials and the advertisements that we see for this talk about a certain percentage of weight loss that you can expect. And the caveat there was because those studies were done in conjunction with diet and exercise. And that's not necessarily, that doesn't come through when we hear about these medications. So when considering covering them as a plan, I think it's important to, if you do decide to cover them in conjunction with diet, exercise, nutritionist, giving folks access to those tools to help them be as successful as possible. The idea is not to be on the medication forever, but without those additional components, folks will find themselves having to take it on an ongoing basis. I heard a statistic today that after stopping the medication, about 11% of your body mass index, there's an 11% increase. So it is important to think about covering it, what that will do for your population of employees. Are we going to see the medical side of the claims go down because we've got this under control? I would say definitely yes. The numbers aren't out there though yet. It's still relatively new. So we don't have, and I was talking earlier today, I hate to use ROI in this discussion, but I think it's important that we all know that we're going to see a good uptick in health, all in all. But right now, we just don't know what those numbers are going to look like. So as far as the 30 to 40% of employers that are covering it, I think that is a very large number. That study has some additional information to it, and I'll make that available to folks. But I think it's important to know kind of historically why this class of medication has not been covered by insurance programs. And it started in the early 90s. Medicaid determined that this class of medications, that they did not have to cover that. Medicare followed suit, and that has just rolled down to the commercial insurance population. Part of the Inflation Reduction Act, I don't know if you have heard about some of the changes that were coming. There was a lot of talk about it in early January. They are saying that part of the Inflation Reduction Act is that starting in 2027, weight loss medications are going to be covered by Medicare. So that's something to look for. And again, knowing kind of how the sequence of coverage goes, I think that tells us a lot about what might be coming down the road for commercial insurance. I want to touch on the cost, which, I hate to put a price tag to this. It is very important. There is a cost associated. If a plan chooses to cover these weight loss versions under their pharmacy plan, let me back up. Just because somebody, you might as a plan, yeah, I want to look at covering these for my folks. just because somebody wants to get on one of these medications doesn't necessarily mean they can. There's going to be prior authorization criteria to get on the weight management GLP-1, just like there is for the diabetic GLP-1. So there's going to need to be certain BMI in place. Are there other comorbidities in place? So blood pressure issues, heart disease, diabetes, that sort of thing. So going through that process to show that those criteria are met, and then looking at throughout the year, we've got some of our PBM partners on the diabetic side. Once someone is approved, they meet all that criteria. Every 6 months, there's a recheck where doctor's notes, just like that were requested to cover the medication in the first place, are asked for again, just to be able to say, did we see a change? Is this moving in the right direction? So I want you to know that it's not, the floodgates necessarily wouldn't be opened up because again, there are criteria in place before coverage would be allowed. That being said, back to the cost, the medications right now are running about $1,200 a month. So at that 40% rate of Americans meeting that category, if you had a group of 1,000 members and 40% were in the obese category and met the criteria and got on the medication, you would be talking about close to $5 million a year to cover this drug at $1,200 a month, times 12, times 400. So it is a costly venture, and it'll be exciting once we have the numbers to see what type of offset in savings there could be for those other things. Lastly on this, I wanted to point out, so far we've been talking about this medication and it's an injectable form. And I know a lot of people are allergic to needles, and I totally get that. In early 2026, Rybelsus is launching, they're waiting for approval to go to market, an oral tablet. That I think will be another game changer. People that are interested in the medication that meet the criteria, I think there'll be a lot more uptick in cover in wanting to take this medication just simply because of the route of administration. Hopefully the injectable options will go down in price, but that is yet to be determined. Okay, so central nervous system agents is another one that is responsible for the increase in cost for the coming year. And these are medications that are used to treat Alzheimer's and Parkinson's disease. There are other indications, but I think these are two their disease states that we can kind of all relate to. The global market spend for these CNS medications in 2024 was over $140 billion. That number is expected to grow a little over 10% between 2025 and 2030. And when looking at that number, down below, I've shown some examples of medications for Alzheimer's disease, and the annual drug cost is a little over $26,000, which doesn't sound that bad, actually, when we're looking at the cost of medication in general. But the additional medical criteria that has to be met in order to be on the medication, there's genetic testing, there's ongoing testing. All of that combined puts the annual medical cost at around $80,000. Combine that with the annual drug cost, and that's why we're getting these types of projections that you see. And Medicare recently started covering medication for this, and in 2025, that spend is expected to be about $3.5 billion. Right. Biosimilars. This is an exciting slide topic because this is something, biosimilars we're really looking at this reversing some of that trend. So, with the bad news kind of is some good news. Biosimilars are, a lot of people want to think of them kind of like a generic medication, which they're not. They're made from living cells versus chemical compound or chemicals that are used to make other medications. But if you think about them being a generic in the sense of they're probably lower cost, therapeutically equivalent in most cases. So the same type of ingredients that go into it. That's why I wanted to include this biosimilar. It's not really versus interchangeable, but is the biosimilar interchangeable? And that means that it may be substituted at the pharmacy level because it's the same thing. And not all biosimilars are interchangeable. So that is why it may take a little bit longer for some of these to for us to start taking them. It takes a little bit longer for some of these to become approved on a drug formulary, things like that. So let's pick on Humira. The first biosimilar, and this was interchangeable biosimilar in 2023, and sales for Humira dropped $5.6 billion. Sounds like a lot of money, and it is. What I should have put on here is what the annual sales were in 2022 for Humira. It was just off the charts. In the biosimilar versions, there are several interchangeable versions available right now. Because of that, PBMs are excluding Humira from their formularies, and physicians, medical professionals are really used to being asked to switch someone from a Humira to a biosimilar option. I would say that the medical community is on board with it. The folks I've talked to, their doctors don't have any issue at all. They do want to visit with their patient before approving a switch, but they say it's the same thing, and it's significantly less expensive. That 85%, you're looking from $7,000 a month, $6,000, $7,000 a month to $800 or $900 a month. So it is a big savings to group health plans. But then for patients themselves, most times when switching to that biosimilar option, the out-of-pocket becomes zero for the patients taking it. So it is really the win-win. It's great for the patient, it's great for the plan, and it is saving everyone money. We've got 10 new approvals as of January 2025. So they are continuing to come out. The other part about biosimilars is, what's interesting is there is a whole new way that they are coming to market that I have not seen before, and I don't know. I've been around quite a while, but I don't know if anybody else has ever seen it either. PBMs are working with drug manufacturers to create private labeling, white labeling for some of these. So Stelara is all over the place right now. You may be seeing a lot of information coming through, webinar invitations, things like that. And I want you to notice that on here, Optum RX right now launched in conjunction with Nuvala. So they white labeled it. They launched the first ever Stelara biosimilar. It went out on the market in January, and there's an exclusivity period through the end of April. So additional options are going to be launched after May 1st. Some of our PBM partners are at that point going to see what the best option out of the availability out there. So CVS Caremark is working with the manufacturer. Express Scripts is working with the manufacturer. So I know they are looking at what which product or set of products they want to add to their formularies. I've heard that around July is when those are expected to be available on other PBM formularies, but it is very interesting that this is how, especially this biosimilar for Stelara is being rolled out through these exclusive private label arrangements. Okay. Gene and cell therapy. The next couple of slides, gene and cell therapy and orphan medications. Gene and cell therapy and orphan medications can be the same thing, not always, but 70% of the medications that are considered gene and cell are orphan drugs. Right now, there's over 900 in the pipeline, and 40% of them are considered to be breakthrough therapy. We were talking earlier this morning about some of these certainly breakthrough medications. They are life-saving, they are life-changing. For the most part, they're a one and done, but they're very expensive. And if you want to go to the next slide, here's a couple of examples, but we've got Barth syndrome down there at the bottom of the slide. It is awaiting approval. It is an orphan drug. So got fast track, priority review. It's a rare pediatric designation. The anticipated annual cost is around $1 million. But seeing that and then hearing what Brett has to say next is that kind of seems like a low price when it comes to some of these orphan medications. We were talking, and there was a set of twins in St. Joe, Missouri, born, and Brett could tell us more here in a minute, year or two ago, and they had spinal muscular dystrophy. Brett can correct me if I'm wrong, but it was about $2.3 million. There's a small window for these drugs to be administered for them to be effective, and they're very, very expensive. We want to make sure people have access to these drugs. We want to be thoughtful about it when it comes to children, especially so. And I want to point this out, not all plans cover this especially under the prescription side, medical side. Brett can talk about that. Jayson can talk about that a little bit more. But I want you to be aware of this if you aren't already. And it does really impact that overall anticipated trend that we've been talking about. Like I flew through that. At the end, if you've got questions, again, Amanda will track those for us. So now I'm going to turn it over to Brett Lane with Voya, and he's going to provide some insights into stop loss in reinsurance.
Thanks, Tracy. I will not give a lot of detail because now this meeting is being recorded. However, I can say that anyone can look it up in St. Joe. It was a hospital system up there, and it's $2.3 million per child, and it went viral. So these people posted on Facebook about it. It wasn't covered under the self-insured employers plan, and then it was in national news. So the employer decided to cover it. So yeah, Brett Lane with Voya Financial. So medical stop loss. I wanted to kind of start with what self-insured versus fully insured, because I know it's a mixed audience. Really, the big difference here is an assumption of risk. It's a funding mechanism. It's federal law versus state law. It's guaranteed expense because you have your defined monthly premium versus a little bit more volatile expense on the self-insured side, but just because you have more control, more fiduciary responsibility. Obviously, your federal ERISA rights preempt any state regulations, so then you're not subject to if the particular state that your site is in mandates a certain coverage, you're not necessarily bound to that because you're federal ERISA rights. So just in general, very, very quick snapshot. And then also on the next slide, I'll talk about what stop loss is briefly, just for those that are currently fully insured and haven't really experienced much from a stop loss perspective. It's purely just a limit of exposure for the employer on a self-insured plan. And every employer decides that amount based on their risk appetite and also the cost associated. So for a 100 life group, they may say, we're going to cap our exposure at 50,000 per employee. Anything above and beyond that would fall on the stop loss carrier, which is who I work for. Right. This is just an example, which I'm sure you all have seen for many years, as far as what are the catastrophic illnesses that are really driving medical spend and medical trend. Premium baby, we were talking this morning, premature babies were pre-2008, they were around $500,000, but then, and that's when medical plans had $1 million lifetime maximums, and the really rich plans had $2 million lifetime maximums. So since then, obviously with general inflation, but also the removal of lifetime maximums for medical plans, premature babies can be, $2 million. Obviously we want to do anything we can to save these children, and Jayson can attest to that. I think the costs have really ballooned for a number of different reasons. But cancers, neoplasms, those are always the top ones on our large claim list. They'll never go away. Hemophilia, all of a sudden becoming one of the top medical conditions because of the drugs associated with hemophilia. Also, when a child is born with hemophilia, the cost of the drug for that child will only increase as they age. So of course, this is a wonderful life-saving medication, but as they grow, the dosage that they need increases. So of course, the cost increases. So yes, we're able to prolong and provide a better life. Of course, just knowing that it's going to impact the overall expense of the medical plan. And then renal failure. The good thing with renal failure from an employer self-insured plan perspective, I should say, is that there is an end in sight. As opposed to hemophilia, you're going to have that claim as long as they're on the plan. Renal failure, it's a 36-month timeline. It starts when they start receiving treatment, whenever Medicare would take over. So moving on to the next, I think we touched on the drugs, and Tracy even touched on that 2.3 million. It was funny that she said that this morning, because the Zolgensma, you'll see about 2/3 of the way down the chart here, right at 2.254 million. So right on the money with what that claim was up in St. Joe. So these are really the most expensive drugs that we're looking at that are impacting medical spend, are impacting trend, are impacting stop loss claims, stop loss premium and renewals. Some of these, as Tracy was mentioning, the cell and gene therapy really are a one and done. So from a stop loss carrier perspective, the idea of all these new cell and gene therapy drugs coming out is a little scary, because if say you're a 100 employee company, your annual spend on medical insurance or self-insured medical plan is around 1.5 million, give or take. And all of a sudden we have a $2.3 million claim in 1 year. Some stop loss carriers could just try and make all that money back in the next year. The approach we've taken, and I think every stop loss carrier eventually will have to do this as more cell and gene therapy drugs come out, is that we've decided to socialize those claims across our entire block of business. So it's about a 2% impact to our entire block. We feel that as opposed to hitting one group with a rate cap 50% increase, removing the rate cap, or anything along those lines that dramatically increase the cost of the stop loss insurance, we'd rather just apply a 2% load across our entire block of business. And then when renewal time comes around, we're not going to hit that group directly for a $2.3 million claim when they're paying us $400,000 in stop loss premium. There's just no way we're ever going to make that back up. So we'd rather spread it across our entire block. So ideally, if you are self-insured, or if you're considering being self-insured, I would just be very diligent about that, because it again just takes one claim and all of a sudden a carrier can increase the premium by at least the rate cap, which could be up to 50% year one. It could be rate cap could be removed the next year, and really the sky's the limit there. But again, cell and gene, those are one and done. It's the hemophilias, those are just ongoing every single year. The 3.5 million you see at the top. So chances are if somebody's at that level, they're going to need that amount of drugs every single year. A stop loss carrier is going to rate for that, because they know they're going to be paying out any claims in excess of the stop loss deductible every single year in perpetuity. So working with a carrier that is doing things from a cost containment perspective, negotiating whatever PBM you're choosing, and ensuring you're getting the best possible pricing from that perspective. Oh yeah, let's talk federal and regulatory. Not a lot going on in DC right now. Very quiet. But from a stop loss perspective, just some of the things we're watching, kind of the current landscape, just the fiduciary responsibility as it falls on employers. Also from a TPA perspective, so who is paying your medical claims. There's been several lawsuits. I won't call it, since it's being recorded, I won't call out the carriers or the lawsuits, even though it's public knowledge. A certain TPA had a lawsuit last year for exorbitant carve-out fees. So when you carve out stop loss, that means the stop loss is not with the TPA. So whatever, an Anthem or a Blue Cross or UHC, the stop loss is with a carrier like a Voya, a Sun Life, a Symetra. The advantage you get, A, is you could get potentially better pricing, but B is another set of eyes from a cost containment and a cost control perspective. So when our dollars are on the line, or stop loss carriers' dollars are on the line, we're going to do an additional layer of investigation when there's a very large dollar amount paid, ensure that the TPA is paying the way the plan doc intends for it to be paid, and also what is considered reasonable from a provider standpoint. So some of these lawsuits are saying, hey, Mr. TPA, you can't charge us this crazy high fee to carve out because we want to have this additional level of control and this additional level of review within our claims paid. Another lawsuit being transparency and data available. So employers were not getting the adequate data from the TPA to adequately shop their stop loss insurance, also just so that they can make certain decisions with regard to their medical plan. So if you don't have the data, you can't make the decisions because you're not informed. Medical trends, Tracy mentioned this, a lot of things driving the trend. I mean, I remember just a few years ago, we were using a 5.5% trend for medical expected future costs. And then last year it went up to 6%. And now we're in the 7 to 8% range. I think a lot of that is due to some of these new specialty drugs, cell and gene therapy drugs. GLP-1s can have an impact on that. Also, just the claim frequency increases. We're seeing a lot more cancers. We're seeing a lot more cancers in younger people, and that always freaks me out anytime I think about it. But it just seems to be getting worse. There's a newspaper behind me, Kansas City Star from 1990, that says healthcare costs are increasing. So even in 1990, we were having the exact same discussion. It's just something new every time that's driving it, and this is really what's driving it now is increased incidences, and then a lot of prescription drugs. Artificial intelligence, kind of a buzzword in every industry, but from an insurance perspective, from a regulatory perspective, the way that we all have to comply, or the way we all do comply with HIPAA regulations, protection of PHI, it's a little scary for some people to think about. So there's a white paper. We had it printed out this morning, but obviously you guys can get an electronic copy from the Self-Insured Institute of America, talking about artificial intelligence as it relates specifically to self-insured groups, understanding the two key components being transparency and accountability. So if employer groups don't know what the AI is doing through some sort of transparency and understanding how it's making decisions, they're not going to trust it, and they're not going to have faith in it. And then if there's not accountability, meaning if artificial intelligence is making a claim decision, but there isn't an additional human layer to review that claim decision to ensure it was made correctly in regard to the plan document, or there weren't certain biases in place, because our natural biases are going to feed into artificial intelligence biases. Those are going to be absolutely paramount as AI continues to increase within the stop loss and medical insurance space. But it's also necessary. So it makes us, we can reimburse a claim for those that are fully insured. As soon as a claim hits whatever the threshold is, $50,000, $100,000, any dollar amount over that, we start picking up the tab. And if somebody gets hit with a $500,000 claim, all of a sudden $500,000 comes out of their bank account. The quicker we can get that claim reimbursed is going to help that company from a cash flow perspective. So artificial intelligence definitely helps us on the carrier side to confirm eligibility. Okay, this person was definitely on the plan and eligible. Confirm that the claim as we received it is a payable claim under the plan document. Remove the individual human piece of that, and it will speed up the claim process in a reimbursement perspective from an employer. So on the next slide. So on the carrier side, it's our dollars, obviously. Anything over the spec deductible, so cost containment is a big deal for us. Negotiating with providers, incenting people to better outcome as well as lower cost providers, negotiating on all these prescription drugs. It's going to help us obviously spend less dollars on the amounts over the spec deductibles, but then it subsequently helps an employer from a renewal perspective. Also, the earlier we're engaged in some of these cost containment measures, which Jayson will really get into, it can help dollars under the spec deductible too. So it has multiple layers. Last year, 2024, our cost containment team actually saved a little over $12 million just by engaging. So again, as opposed to a TPA that's just paying the claims and then here's the amounts over spec, we're engaging and seeing where we can save dollars. The largest amount was in transplants. So not only negotiating with providers on those transplants, but also helping people find preferred providers from an outcome perspective as well as a cost perspective. And then $4.5 million was a pure claim review. So again, just kind of diving into the claims that are being paid by the TPAs. And then 1.7 million of that savings was pharmacy specific. In addition to cost containment on the next slide, we talk about large case management. So if we're engaged early in managing a claim as it starts to creep up towards that spec deductible, obviously we're going to be able to save some dollars there. We spoke earlier about transplants, but also if we're engaging with an individual that's might have a high-risk pregnancy, we're telling them, hey, you need to get to the doctor more often, seek care earlier and often, and then ideally it won't be necessarily a spec claim. On the next slide, so how can we help the employer group when we're doing these cost containment measures? It's not just our dollars. These step-down deductibles is one way of doing that. So if we're able to get somebody who is in kidney failure to seek care at a dialysis clinic that is a preferred on outcomes and cost, we can reduce the spec deductibles, which is reducing the employer spend. Perfect timing because my throat is drying up completely. So some of these cost containment programs that Jayson will really get into, there's a number of different layers. It's not just the three that I mentioned, but cancer dialysis, transplants, transplant carve-outs from a stop-loss perspective, specialty pharmacy. I mean, I don't need to read all these to you. And of course, cell and gene is always going to be there. But these are really the areas that we're focused in, not just saving our dollars ideally, but then positively impacting stop-loss renewals and hopefully saving some dollars before the spec deductible hits. Let Jayson get a little more detail on the cost containment programs.
Thanks, Brett. It's good to kind of see everybody this afternoon. Thanks for attending. I promise it's not all doom and gloom. The purpose of this is just to let everybody know what we've been noticing in the market and kind of the things that we're tracking currently, because there's a lot coming at you guys constantly. There's a lot that we're tracking constantly as well. So just being able to give you an idea about kind of what took place last year and then what we're looking forward to in the future, but also how do we help mitigate some of these creeping expenses or these large things that are happening in the market. Next slide, please. So first things first, right, is how do we handle high claimants? Well, we have to identify them first. And the data that you guys have access to and that we have access to helps us to do that. It's critical in any strategy conversation that we have, whether it's on a quarterly basis or mid-year basis. But trying to make corrections or put things in place, products in place, services in place that can help reduce some of those exposures. So we need to determine, number one, is it medical, is it pharmacy, or is it a combination of the two? And then from there, we want to take a look, right, kind of a step down and see, okay, well, what percentage or how many claims have we identified that are at 50% of the pooling point for those that are fully insured, or at 50% of that spec level. And just so we're all kind of talking the same language here. Everything that Tracy and Brett have discussed today on self-insured side, we still have the same components on a fully insured contract. We just don't see it because your program is bundled together, where in a self-funded program, typically, right, we like that unbundled approach, so we have a little bit more control and transparency in what's happening. So we want to look and see how many of those claims are at 50% of the pooling point, so that we can now anticipate and discuss again a higher level strategy on how to help those particular members, but also how we can help manage the program effectively to help either at renewal time in the immediate future or 2 to 3 years down the road, identifying chronic conditions, high cost pharmacy, those sorts of things. And it might be even something as simple as, hey, we have a really high population of ER utilizers. okay, well then let's create a communication campaign around the importance of not using an ER as your primary care physician, right? If I get stung by a bee, I can go to an urgent care. If I got in a fight with a beehive, though, I probably need to go to an ER. So helping to make some of those distinctions can save some money on the front end for not only the employer group, but for the member as well, and the rest of the employee population as we're trying to keep those renewals in a favorable light. Next slide, please. So some of the out-of-box ideas and strategies and services and those sorts of things that we're implementing or we're having discussions about with our clients for medical conditions specifically. It does apply to pharmacy, but pharmacy, somebody could stop taking that medication. It may not be working anymore. They may be going a different direction. So really, we do see it typically more on the medical side, but as a foundation where we can put that person in a foundation type of program where 100% of their out-of-pocket expenses are covered up to whatever the plan's deductible or out-of-pocket max is, excuse me. There is a fee that's associated with that. So as we're talking about pooling points and specific deductibles or spec levels, if you will, $50,000 on those caps up to $100,000, the fee that's associated with these foundations generally is around $50,000. So if we have a $100,000 spec or pooling point, we spend 50 grand to put this person into a foundation plan. Not only have we saved the organization money, 50% of whatever that point is, but now we're also helping to protect the reinsurance, which ultimately helps to protect the renewal at this time and then in the future as well. And that really is the name of the game right now, is reinsurance protection. What that is, that right there in and of itself can help drive that renewal up. If we're not mitigating risk, and Brett can attest to this, if we're not mitigating risk and we're just letting claims run, we're going to get a nasty renewal every single year. And our goal is to understand the decisions that we're making now and what impact those are going to have at renewal time, but also what impact is this going to have 2 to 3 years down the road? And is this going to serve the organization, that member, and ultimately the entire population? So those are the things that we're trying to look at when we're evaluating a medical foundation to put somebody who may have a chronic kidney condition or a heart condition into one of those situations. One of the other things that we look at often is the PBM, or the pharmacy benefit manager, and the pharmacy program in and of itself. It's the lowest hanging fruit in the market right now in terms of what we can control, but it has such a huge impact, as you heard Tracy and Brett talk about. So number one is just evaluating the PBM. Are we with a PBM, number one, that is giving you, the client, 100% of your rebates, that's giving you upfront, purchasing cost, there's no spread pricing involved, and are they giving us the accurate data that we need to make informed decisions? So, and that's where somebody like Tracy comes in and is vital and to that piece, is to understand that PBM contract and how it works with your TPA, with your carrier, and then what the effect is for the program itself. But another piece of that is, as we're analyzing those claims, if we start seeing a lot of pharmacy claims that are ticking up to that either pooling point or that specific deductible, is carving out specialty drugs. Excuse me. And that can be a little scary at times, because then the question is, well, where are we getting these drugs from? So there's a program that we've implemented with some of our clients. I have one here in Olathe. We put this program in place about 18 months ago. And what it does is, for any drug that costs over $350 a month, they reach out to that member, they engage that member, and they collect some information from them, excuse me, and they look at one of 3 avenues to help this member get their medication. It's either a manufacturer assistance program. If that member doesn't meet the eligibility requirements for manufacturer assistance, then they look at international purchasing. If they can't source that medication through an international avenue, then they look at foundations. If they can't source it through foundations, then ultimately it rolls back up under the plan. But for this particular client of mine here in Olathe, through 18 months, we were able to save $750,000. So a massive, massive savings for them. in the immediate, but also the impact that it's had on their reinsurance has been tremendous. About halfway through the year last year, when we had our mid-year partnership meeting, their renewal was at a -4 at that point in time. And a large part of that was due to how we were managing the pharmacy risk that was removed from the plan without disrupting too much of the how the employee gets their medication. So we're saving about 75% on medications that are sourced through that avenue for you as the employer. Generally speaking, there's a member savings where they're not paying anything for that medication. All of that being said, it's a wonderful program. It is a disruptor. I want to make that perfectly clear. It is designed to disrupt the way that pharmacies or pharmaceuticals are delivered, how it's managed, and how it's paid. So there will be noise with that particular program, but it's one of those things where we have to look at the data, right, and assess and say, okay, is the noise worth the reward? And so those conversations, right, are had with you, the client, and then we need to create some sort of a communication campaign to let folks know that this is coming. It's okay to ask questions, but it's going to be here. If they reach out, you have to respond. You have to engage with them. But it is a fantastic program. And like I said, it's just another one of the prongs that we use to help protect that reinsurance so that we can deliver a favorable renewal. Excuse me. One of the other avenues that's a little less talked about, just because it's a little bit more rare, but is going directly to the pharmacy manufacturers themselves. So not the pharmacy benefit manager, not the Optum, not the Express Scripts, not those folks, but going to who actually makes the drug. So we have a client here in Kansas City. They had a member on their plan who was on a very specific drug, and that drug was $400,000 a year. We couldn't figure out why that drug was so expensive. So we actually, Tracy and that particular consultant reached out to the oncologist, had a conversation with him about it. He helped us get in touch with the actual manufacturer, and through conversations with the manufacturer, found out that drug actually cost $150,000. So the PBM was marking it up an exorbitant amount of money. So we created a contract with that specific manufacturer to purchase the drug directly from them. Now it didn't go to zero, but we went from 400,000 to 150,000. So partnering direct with manufacturers can really be a benefit if we can't source that medication through another avenue. And then marketing campaigns is on here again because communication to the employee population is so vital. It's so important. I mean, it could cover a whole host of things. One of the marketing campaigns we did with another one of my clients is they're a blue collar workforce, pretty much a male dominated environment, and a lot of those guys like to hunt, fish, ride ATVs, all that fun stuff. So we created a wellness program and we called it Bucks for Bucks. So like beers and money. It was kind of cool. But it was more around, if you're out hunting, fall out of a tree stand and break your leg, if you get snagged on a barbed wire fence and get a pretty nasty cut, those sorts of things. Don't be out in the field at 4 a.m., drinking beer, shooting off a rifle. It sounds silly, but people are people, and we're trying to mitigate risk. And oftentimes folks don't think about your benefits program as a risk mitigation tool, but it absolutely is. So if we can work with a safety committee to create not just a safety culture in the office, but at home as well, it's equally as important. The other one I like to do is around the summertime, just around, summer safety, but can end up on your medical claims. If I am at a 4th of July party and set off a firework and lose a couple fingers, Miller Group is going to see, right, a nice claim come through. So creating marketing campaigns that have to do with safety, but also wellness or well-being for an employee around seasonal activities, I think is really important and really helpful also. And it's not just the extreme things. It might be if you're working out out in your backyard during the summer, are you covered properly? Are you wearing sunscreen? Are you hydrating appropriately? Do you have both eyes on your kid when you go to the pool? Just those sorts of things that seem like easy layups, but it makes a world of difference. The difficult part is it's hard to quantify what doesn't happen. But I like to think if we're pumping those things out, that people are paying attention, and maybe they make that last minute decision to, oh, I need to wear long sleeves if I'm going to be outside all day, or I need to wear a ball cap so I'm not, I don't get heat exhaustion, or I can cover my face and not have to worry about a nasty sunburn. Next slide, please.
Jayson, is it safe to assume that you moved that client's PBM services away from that PBM?
Yes, it is. We did put that client with a different PBM. So just some additional ideas. Everybody on this call gets hundreds of phone calls a week from folks like me, other vendors, other partners, and we do as well. We've got everybody in the country chomping at the bit to get in here to get access to you guys. It's our responsibility to vet those new carriers and those new partners. It's not always going to be a fit. As we're listening to those pitches, I guarantee you every producer in this office or every consultant in this office is thinking about, is this a good fit for that client or for that client or for that client, or I'm dealing with this issue that doesn't work. But that's what we do. We evaluate new carriers and new partners to determine if they're going to be a benefit to you and to your members. One of the easiest ones is a third-party administrator that we've partnered with that does fantastic work. And one of the reasons why we really like them is they do kind of a behind-the-scenes claims adjudication review. So before they adjudicate claims over a certain amount, they're reviewing those things. And in 6 months with one of my clients, they were able to save that client $80,000 just on doing a claim review. They're finding things that had been double billed, incorrectly coded, services that weren't rendered were added. So, we do have a human element on the other side of those medical billers or those medical coders. This is just double checking or triple checking the work to ensure that it's accurate. Those dollars saved don't show up on your spec. They don't show up on your reinsurance. They don't show up on your pooling point, and that money stays in your pocket. And that's the most important piece, is that the money stays with you and it stays with that particular member or that family. There's another trend that, and I shouldn't even say trend, but another avenue that's catching fire, and that's direct primary care. So we are in that particular model, we are discarding networks. We are going directly to a provider for a contracted rate per month, per individual, or per participating member, where that member has access to that physician, whichever physician they get assigned to. And there's a little bit more quality of care that's delivered in those direct primary care models. You as the member are getting longer consults, right? We've all been in the waiting room for 45 minutes. You go in to see the doctor, they walk in for 5 and they're out the door. This model, the provider is supposed to take a little bit more time with you to understand what's going on, and they may prescribe things that is not a medication. It might be a lifestyle change. They may direct you towards other avenues of, hey, I want you to see this dietitian or this nutritionist, or hey, let's talk about your sedentary lifestyle, and how can we help affect that change and help keep you healthy. So that is another avenue worth exploring or worth having a conversation about. But most importantly, anything that we present to you as a recommendation or an option has to fit your company culture, right? Does it make sense to have a direct primary care that's here in Kansas City if you're scattered across the country? Probably not, but let's see if there's an option where we can do that on a national level. So that's one of the other things we need to take into consideration. Well-being solutions is on here. Smoking and non-smoking, that is still a massive campaign. And actually, I probably should have added just straight up nicotine now, because there are nicotine patches that don't have tobacco in it. But if we are helping folks to stop smoking or to stop using tobacco and nicotine products, we're improving heart health, we're improving lung health, reducing the risk of stroke, and all of those morbidity classes that come along with nicotine use, which that's been a massive campaign for decades. And as long as people are smoking and now vaping, it's probably not going to go away anytime soon, but it is something that we talk about pretty consistently in our meetings. And one that seems kind of smaller in the sense of what we've talked about today are just simple biometric tests, right? Having your folks get their blood work done, get their weight taken, have their pulse checked. All of those sorts of things, they add up. And I was actually in an open enrollment meeting last year where we were talking about a wellness program and an incentive program that had been put in place. And one of the employees actually stood up and said, I wasn't a believer in this. I did it last year and actually found out that I was diabetic. He had no idea he was diabetic. So we can help from a proactive nature, identify either chronic conditions that are ongoing that people don't know about, or catch people before they have those chronic conditions. And the point of that is to identify those folks so we don't have a claim that spirals out of control. Right. So if we can catch them on the front end, help them manage it, help them through the education and understanding what that diagnosis means, then it's worth its weight in gold. And kind of leading into the diabetes and weight management programs. Excuse me. If we can put in a program like a Livongo, for instance, that helps with diabetes management, especially for somebody who's just recently received that diagnosis, helping them understand what their A1C level means and how to manage that, getting them free lances and strips, the free equipment, but whatever we can do to help keep that member out of the hospital, out of the ER room, out of a hospital admission, saves the member money, it saves the organization money, and really kind of, like I said before that claim spirals out of control. Next slide, please.
That's it. That's your last slide.
Awesome.
Okay, so now we have Q&A. First, before we hop into the Q&A, I just want to thank Brett, Tracy, and Jayson for sharing the information with us. But I know this is a long time for a webinar, so we'll hop right into questions. So thank you, everybody, for staying with us. First question is, does script sourcing cover GLP-1s?
So yes and no. With script sourcing and some other sourcing vendors like them, they will only source medication that is covered under the pharmacy benefit plan. So a GLP-1 would have to be filled at least one time through the pharmacy benefit. So the pharmacy benefit plan would go through the prior authorization process, all that good stuff. If they determined that the member was eligible for the medication, they met all the criteria, they would fill that the first time through the PBM. At that point, if in Mounjaro and Ozempic have been available through these script sourcing, through international programs specifically, there are shortages like we talked about earlier. So if it fills through the pharmacy benefit plan first, then it's eligible to go internationally. At that point, yes, script sourcing will fill it as long as there's not a shortage.
Next question is thinking back to Brett's slide where it was the 10 high-cost pharmaceuticals. Are any of those known to be are any of the conditions that were listed, are any of those known to be disabilities that could qualify them to enroll in Medicaid and come off private insurance?
ESRD, end-stage renal disease, is really not the easy one. It's the one that I know is an automatic. So once somebody's been diagnosed with end-stage renal disease, it is a 36-month clock, and then after 36 months, Medicare starts to pay primary. There could be others. That's the only one that I'm really aware of from a stop-loss perspective.
Yeah, and ESRD, or end-stage renal disease, or chronic kidney disease as well, kind of falls into that same bucket. And that's one of the responsibilities that we as the broker have. And I know that there's a question in here about group size and what can we do if we have the data that says that claimant's been identified, because it's going to come through with all of the testing and the biopsies and all of those things. So we'll see that diagnosis. That's when we reach out to either the carrier or the third-party administrator, the TPA, and say, hey, we need you guys to reach out to this particular member, get them the necessary applications that they can complete, and we can get that turned in so we can start that clock. And then if there's anything that we can do within the first 30 days of that diagnosis to get that person in-home treatment, or not in-home treatment, excuse me, in-home training, I believe that can help speed up that 36-month clock. But Those are the, I would say, kind of quote unquote two. I know they're both kidney disease, but that come to, that are top of mind.
Okay, next question is, are carve-out programs available for fully funded plans?
So the one that I had mentioned with my client Olathe, that program is not accessible in the Kansas City or Kansas or Missouri market. If you happen to be in Texas or Arkansas, it's a different story. Geography can play into that. But as it stands right now, that particular program would not be available for a fully insured group. But one of the things we could look at would be like a script sourcing. But what we're going to run into would be a scenario of you're already paying a premium for access to the PBM through that carrier. And now you're going to have a percentage of savings that you're going to be paying to a program like script sourcing.
And something I'll add to that is with being fully insured, we don't have access to data like we're talking about, which means we don't have access to claims data that we can send to script sourcing so that they can identify, proactively get involved, and all of the things that go with it to make a program like that successful. So it's difficult, and it's not ideal to run it that way. And it's just on the international piece. We can't do manufacturer assistance that way, like Jayson was saying.
Right. And what we also run into is, so because, like to Tracy's point, it's a voluntary program at that point. So we're relying on a really good communication strategy and campaign every month throughout the year to let people know that they have access to this, that they need to go to this website, they can check this list and see if their medication is on there, and if it is, then they reach out directly. So you can do it, it just won't come with the integration that a self-funded group would have, because we're not able to get those certain set of claims data that particular vendor needs in order to reach out to the member and put them through the eligibility process.
Jayson, what's the smallest group you guys have that's self-funded?
That's a good question.
100%. Like 50,
I think
100 lives, 50 lives?
No, actually my group in Olathe, when we took them self-funded, they were 80.
Yeah.
But I can't speak for the rest of our book of business. I'm not entirely sure. It's not below 50 though.
Yeah, and I was just mentioning that because there are a lot of 50, 75 life groups that are self-funded, because there was a question about access to data. It's a much lower specific deductible. There's a limited number of carriers that work in that space. The premium is very large. It looks like a fully insured premium, maybe a little bit less because you're avoiding some taxes. But then you have the flexibility and the access to information.
Yeah, and whenever we talk about self-funding, whether it's self-funding on your own, in a consortium, or in a captive, when we really dive into it and we start talking about like your variable costs, what are your claims coming in at, or what do we expect you to spend, there's some sticker shock that can come with it. So if going that direction, just to have access to the claims and to be more strategic is interesting to you, then but you've got that sticker shock. One of the things that we could always look at would be taking you level funded first. It looks and feels like a fully insured product, but there's certain aspects of it where we get a little bit more information on what's happening inside the plan, and you kind of feel what it's like to be self-funded. We do that for a year or two, right? Kind of baby step into it. And then if you say, hey, we're ready to make the jump, we feel good about this, then fantastic. But more and more groups below that 80 life mark are going self-funded, just because products have come down in the market space to allow that to happen. So now we have, we've got critical mass in some of these programs where the volatility of those claims kind of even out over time. So it is becoming more realistic where we see some of those smaller groups moving in that direction.
Did you guys answer Suzanne's question? Like, do you have any additional advice for fully funded groups?
Yeah, so
under 100, I'm sorry.
Yeah, so for groups under 100, oftentimes they're centrally located. So HR or executive level or even managers know kind of what's happening with their people, right? So and so is out on STD leave. So and so is getting ready for a big surgery, whatever it is. So I mean, I never discredit, ears to the ground information from any group on what's happening inside their population, and it can help us in that planning stage be strategic. As far as getting data in those below 100 size groups that are fully insured, when we get that renewal, we're asking the carrier to justify this increase. Tell us about the large claimants. They'll give us some insight. They may not give us exactly what's happening, but they'll tell us, hey, the loss ratio for the last 6 months was X, or hey, you guys, the group added 2 large claimant above, 50,000, and they've got 4 that are 50% of that right now. So that's where the relationship with the carrier comes into play. It is really important for them to be willing to do that, because in Kansas and Missouri, they don't have to give us anything if you're below 100. If you happen to be in Texas, we can request some things, we can get some information, but otherwise they keep that thing pretty well under lock and key.
If anybody has any other last questions to type in, we have just a little bit of time left. But while I wait to see if anyone else has a question, please watch your email this afternoon. We always aim to get it out same day. That email will have a link to this recording. It will have contact information for Tracy, Jayson, and Brett in case you need to continue a conversation, or maybe you have a question you want to ask just one-on-one instead of a group setting. Their information will be in there. And then it will also have some of the resources that we mentioned today. Brett mentioned a resource, Tracy mentioned a study. So we'll include those in that email. So I haven't seen any other questions come through. So again, I want to thank Tracy, Jayson, and Brett, and Aaron as well. Thank you everybody for joining us. I know this was a long one, so we appreciate you taking the time. Have a wonderful afternoon.
Thank you, everybody.
Thank you.